there's no easy way to tell a patient or a patient's family that what is about to happen is death. There's just no easy way. And most who work in clinical ethics describe themselves, sometimes with gallows humor, as being the harbingers of bad news, and many actually will say that their role is to be the death consultant. So often, then, what goes on in a clinical setting where patients and families have got to cope with a reality that maybe they haven't embraced yet, is that the ethicist is faced with a challenge that perhaps shouldn't be a challenge for the ethicist. Maybe it's just not appropriate, in fact, that we be asked to do this, and that's to deliver bad news, to translate bad news, moreover, into a language that's neither patronizing nor obscure. Oncology is the discipline of medicine that has been hammered most over the years for its purported inability to let people know about where things are going in their lives. Why? Because oncologists are often told that what they're really about is providing a last-ditch option. The perhaps lottery odds that family members and cancer patients ask for when they say, do anything, get me enrolled in a trial, and point to treatments that have at best a 1 to 3% chance of success in just keeping them alive over a 2 to 3 year period, in which those patients presented with those opportunities, most oncologists believe, and correctly, that the patient will select them. It's hard then, when that kind of thing fails, to talk in terms of dying. And so there's a whole, you can actually pull a dictionary out. There's a whole kind of array of euphemism that's used to say, you're going to die. It ranges from, at the far outside, the kind of commentary that sounds like, I believe we've done pretty much everything we know how to do, and at this point we're just examining every day how she's doing or how he's doing to see what our options are. I say that's at the outside because it does three things. It conceals the nature of the available therapies, deliberately or otherwise. It just says, we think we've run out of what? Right? It as a way of talking, suggests that what it is to provide good care to a family or a patient is to keep searching for the miracle bed, to keep trying to identify, in the face of the obvious reality that there is no standard of care therapy that will provide treatment likely to help a patient get better. Right? That in the face of that, you still are going to continue to search for something because that's an appropriate thing to do. Or to put it better, because that's your job. So an oncologist often, and again, this is to use oncology in a way that maybe is just, as you'll see in the movie Wit, it's because oncology is always blamed for this. Plenty of oncologists who don't behave in this way. But the third piece is the piece I want to focus on. It is very, very difficult to say to someone, die. I mean, if you actually spent a lot of time in your career in a healthcare environment, count the number of times that you hear someone say you're going to die. You just almost never hear it. You'll hear language that's religious more often than you hear language about death. So someone may pass, we may be unable to save them. Language about the failure of rescue might come into play. But the point is that families who aren't ready to hear that a patient is going to die will grasp on whether their relative is just a couple of days old or 95 years old, to any bit of hope. And in the cancer example, as I point out, if you're looking for a way to fight against all odds, then the idea that, we've done pretty much everything, we believe that things are not going well, leaving out the word they're going to die, the phrase they're going to die, pretty much leaves open the garage door to a whole panoply of activities that might not be the best thing for a patient. So an ethicist who's brought into that environment is brought in, as I think happens maybe in the majority of ethics cases, with a job that is nearly impossible. Without having treated the patient, without having spent a lot of time with the patient, the ethicist is being asked to say something no one else will. And I think it can be done fairly well. In fact, I think it's one of the skills that as we talk, we should talk most about. What would you do if you were called in on an ethics consult where it became clear to you just right up front from a comment like, we're not sure how to get it across to them that there's no more hope. We don't think they're hearing us, right? How do you construct out of that a way of telling a parent or a husband or someone else in the family that really this is it? Your relative is going to die. Or worse yet, telling a patient, we've run out of options. I mean, we don't have anything else to offer you. And more than that, we believe that offering you nothing, the so-called null hypothesis, right, would be better for you. Better. It would be, and now I'll really lay it on, it would be the best care we could provide. That's a kind of language that we just do not have in the contemporary healthcare system. Only in hospice and palliative care has that way of talking really evolved. So we teach medical students to be empathetic. We teach them to talk about and think about what it is for patients to die. There are countless movies about how difficult it is for physicians to really relate to it, but nonetheless, it's the critical question because lots of people do die in hospitals. And so from that emerges a core, right? And the core is, when you're talking about the end of life, what is it exactly that you want to present? I think there are three really critical things that clinical ethicists don't remember or don't learn that can be very helpful in dealing with patients and their families, but also in the teachable moment that every clinical ethics case presents. The first is this: people should never say, ever, that they're going to discontinue treatment. And more importantly, they should never say that we believe that the care that we're providing is failing, or we don't have any additional care to provide. Now, look, this is a country simple kind of point, and yet it's a point that again and again and again I find myself making. Why is it important? Because what you can offer a patient when they near the end of their life is the most aggressive thing that a physician really could ever provide. And that's the aggressive application of conversation, of palliative care, whether that's a medicine designed to reduce pain, or whether that's the kind of conversation about where do you want to die, or what does it mean to you that you're dying, or what can we do to help you as you die live through that dying period right up until it's something you can't live through anymore. I'll put a fine point on this, just to put it as clearly as I can. What we do, I think, when we're effective in talking about the end of life and discontinuation of some treatment is to say, we know you want us to do everything, and we're going to. And what it means to do everything now is to provide every bit of care we can so that your relative is able to experience the last weeks or days or even hours of their life with the highest quality that's possible. And when a family member then says, well, isn't there anything else you can do? You have to be straightforward, right? That, and this has to be, everybody has to be on board before the ethics consult. Straightforward. That the answer is, there are no more therapeutic measures available. So that leads me to my second point. It's extremely difficult at the end of life to make the most important distinction of all. That's the distinction between therapies that are therapeutic, therapies that are merely evaluative, and things that are, from one point of view or another, futile. The therapy that is, as I talked about earlier, therapeutic is therapeutic because it's treating either the underlying disease or, if what really matters here is the symptoms, because the underlying disease doesn't respond to treatment, but treating the symptoms is doing the patient a great deal of good in everybody's mind, well, that's therapy. But if you can't do that, then you're in the other categories, right? Evaluative care, like providing a respirator in an emergency room, is aimed at opening a window so that you have time to examine what's possible. But what happens all too often is that patients get caught up, as I'm going to talk about in my next lecture, they get caught up in the idea that because a machine is on, turning the machine off constitutes killing them, right? And so a respirator that has been used for the purpose of determining that a patient is not going to live can become a burden beyond any other possible burden, because it begins to take on a life of its own, and that's reinforced by physician language about the respirator, or just the failure of physicians to talk in a way that's very, very problematic. And then, of course, there's this final piece of it, which I think is maybe in some ways the least important piece, which is that we have to find a way to use the power, if there is any, of clinical ethics, not so much to help people die, because let me tell you, two things are true. One, you will burn out very quickly as a clinical ethicist unless you have just extraordinary resilience in this regard, acting as essentially a funeral home person. I mean, the task of telling someone they're going to die is a courageous task, but if you are acting as a clinical ethicist, you are not the combatant. You are not the physician treating the patient in a clinical sense. And so what you're doing in delivering that news is becoming a mediator. You are, the bearer of bad news, and all you get to say in your defense is don't kill the messenger. So you can act in such a way as, here you've been brought in as the person to resolve a conflict, and you just agitate it. Because in the absence of really good language and in the middle of a firestorm that's almost always caused by somebody thinking that somebody else has failed, and profoundly, you're not going to really help in that regard. But what you can do is to help clinicians think differently. You spend any time at all in a healthcare institution, it becomes clear which units are going to call you for whatever reason. And within those units, which clinicians have the most important set of issues that you can identify. Clinical ethics, for me at least, is largely about teaching. And I don't mean that to be patronizing, it's just to be blunt. Physicians call us because they want that. They want to know how to do that better themselves. They don't want to have an ethics consult every single time something happens. So I think understanding that there are teachable moments has several parts. The first piece is, for some physicians, they're going to find that interesting, they're going to be willing to listen, and then as you come back and have conversations with them, which you should, coffee, etc., you'll find that they are receptive, and that not only does their behavior change, but they become real parts often of the ethics committee or even of the clinical ethics service. The other option is they'll hate you. And you will discover that in clinical ethics too, there's not only the risk of malpractice, but there's also the risk that a unit will just simply stop talking to you because you are the person who makes patients unhappy. Patient calls for an ethics consult, you provide them with bad news. The physician wouldn't have provided it that way, and now look, here you are, and you've made a whole family unhappy to the degree that they will present a risk at every level for the hospital. And the final patient, the sort of ideal patient, frankly, is the patient who, very much like you, might decide that this ethics stuff is really interesting. Remember, bioethics is the fastest growing discipline in academic medicine. And I am stunned at the degree to which people who say, I hate this ethics stuff, I'm not sure why they called you, okay, let's talk about it, become the ones who apply for a master's program or a certificate in clinical ethics because they themselves start to think that this is interesting. And they notice things in their own practice that haven't been written about, whether it's children who want to discontinue treatment and how individual patients and parents respond to that, or whether it's about nurse-assisted suicide. Those physicians and others represent, in my mind at least, the bulk of the most interesting students who come as mid-career clinical professionals, and they always contribute a great deal. So teachable moment, I think that's the fundamental issue, even though ultimately, at the end of the day, end of life for a clinical ethicist is always going to present the kinds of problems that are in the cases that Professor Otto talks about. So it's learning, it's thinking, it's being ready for complexity, but I would argue perhaps least important but most interesting, it's a teachable time, a time to not so much teach the patient and their family as to pull aside the unit and get involved in what I think of as proactive ethics.